Sure.
Guys, bye. Good luck.
Okay. Okay. Take care. Take care, George. So, so we start the webinar from the platform of the Miom Academy, and it's honor for us to hold this webinar, and we are thankful to Dr. Muhammad Al Amri for arranging this platform, and obviously he is doing great in terms of webinars and arranging the meetings every year in Dubai. So this year also there is a meeting in Dubai from 3 to 5 October 2024. So we have list of very eminent speakers from all over the world, from USA, from Turkey, from Brazil, and from Mexico and Argentina. So I would like to invite our first speaker, who is very well known in the field of macular buckle. So he is with us, Dr. Levent from USA. Dr. Levent, kindly present your case and give a brief introduction about yourself.
Yeah. I'm so honored to be here, and dear friends and colleagues, it's a pleasure to be here presenting that. Today, although I'm working pretty hard on that titanium macular buckle, actually my presentation today is not on it, but this is something currently, all of us in the field either has seen before, or if you haven't seen, probably you'll see a case like this. And let me share my screen to start.
Yes.
Suprachoroidal, sorry for the typo, suprachoroidal silicone oil in a case. And this is, I'm going to be talking about, this is a complication, obviously. I'm going to present a case, and I'm going to tell you at the end that best way for not to deal with that is to avoid from this to happen. And I will tell you some tricks and clues and what to pay attention for it not to happen, to avoid it. And say you've come across with a case like that, or during the surgery, or you have a patient with that later, what to do. I'm going to recommend to remove that oil from the suprachoroidal space. And then we're going to talk a little bit about the prognosis of what happens to those cases afterwards. So far, I have come across with 2 cases as such. One was 1,000 CS oil, one was 5,000 CS oil in the suprachoroidal space. The case that I'm presenting here is a 55-year-old female, and patient had a second recurrence of retinal detachment after vitrectomy and silicone oil placed. And in that case, a 1,000 CS oil was used. And this patient was referred to me with a still existing retinal detachment associated with suprachoroidal silicone oil, which was not actually noticed intraoperatively, as said by the referring physician, referring surgeon. And later, they saw that there was oil in the suprachoroidal place, as well as retinal detachment still persisting in this patient. The patient was phakic, young patient, phakic with no significant cataract, and patient's vision was counting fingers at 1 foot, and intraocular pressure was on the low side, 9. You can see the picture of that case prior to surgery. There was oil extending in the temporal area, periphery basically, but it was also extending some into the macular area. Retina was detached in the macula. There was no oil under the subretinal space. It was all in the suprachoroidal space. First of all, best thing is to avoid this complication. So how did that happen? Sometimes we see that happen during the surgery. We're injecting oil, then all of a sudden red reflex turns to whitish, that where the oil is going. Best thing is to observe the injection cannula if you're injecting with a cannula like in this picture, and make sure that the tip of the cannula is always in the vitreous cavity while you're injecting the silicone oil. And if you're injecting through the infusion cannula, make sure that it's not retracted back so to the choroidal space. And sometimes we put those trocars a little bit on the oblique way. Slight retraction of that may make the tip come and stay in the suprachoroidal space. And if your way of doing such surgery is by direct exchange of oil with perfluorine, then you may end up injecting into the suprachoroidal space through the infusion cannula. So just to make sure that in that case as well, it's in there. So another way that oil goes in that we're not really injecting into it, but later we may find if we did a large choroidectomy for a tumor, such as rarely done, or in an eye with severe trauma and choroidectomy done, that there is a large space for the oil to pass into the suprachoroidal space, and then pre-retinal membranes pulls the choroid and retina forward to let the oil go back. Sometimes later in the postoperative period, oil may get under the choroid and into the suprachoroidal space. Of course, we never let air pass into suprachoroidal space. This is a life-threatening thing. There have been cases reported, but I am not aware if oil can pass into venous circulation from the vortex vessels into the circulation. Affects small emboli may be happening. We're not aware of that. May be another research topic for future for people who might be interested to think further about it. And removing that, if you get it into the suprachoroidal space, remove it. So don't leave it there. Removing it, when you're going to remove it transsclerally, externally, and make your incision sclerotomy in the most elevated part, right on the, so that you're not getting into choroid or the retina, but just into the suprachoroidal space. Then sometimes you may need to do multiple drainage sites. And some posterior oil posterior to the area of sclerotomy that you're making can be pushed anteriorly with a scleral depressor. Oil, fortunately, floats up a little bit in that situation. It's not that difficult for it to push forward. And I've done that in those two cases, one with 5,000, one with 1,000. Both of them are easy to displace forward and get it out of there. And there's a little bit of maybe staying behind, but it's easier and better than anticipated when you drain it. That comes out rather easily. And there have been some cases in presentation that pushing it from inside with perfluorocarbon or higher eye pressure has been tried and reported in the past. So this is the case I'm presenting that was done with 1,000 CS oil. Patient is phakic. Patient came to me with oil in the eye already, but the referring physician noticed that oil was, some of it was injected into the suprachoroidal space. During the procedure, the retina was still detached. First thing I did was just to place the pores 23 gauge, one sclerotomy to let the existing oil drain out with from the just a large sclerotomy. Everybody has different ways of removing oil. That's how I remove my oil, 1,000 or 5,000 doesn't matter. This is much, much faster than putting a cannula, aspirating it. I just let it drain, making like a 2-stitch size, about 2.5 to 3 millimeter incision. And then I spread apart the sclerotomy. And there's choroid always something trying to be bulging out and or preventing, so I cut it out, and in a minute or two, all the oil is out. That's how I drain it. And then usually two vicryl, 7 vicryl closes that suture. So that's how I do all my oil removals. And this was a 1,000 oil, easy to emulsify. Some came to the interior chamber, and it was aspirated with, let me just stop for a second, aspirated with a 30 gauge cannula, because if you don't, then your view is pretty disturbed during the procedure, that you don't want those bubbles stay there, which later gets into the angle and might cause increased pressure as well. So I always, when I remove oil from eyes, I always drain anterior chamber, little emulsified droplets as well. And this is the case with the choroidal detachment, most prominent in the temporal side. This is surgeon's view. This is the right eye. And macula is detached, retinal detachment with some oil extending all the way near the macula. In fact, it's hard to appreciate a little bit in this. So all the oil is out. And then I'm looking where the most, this is actually choroid, not subretinal oil there, you see. So I made 2 sclerotomies just to drain out and opening it, just a normal pressure in the bottle, not high, not low, just whatever I do, about 30, 40 millimeter mercury bottle air pressure. Then draining some more of the posterior by scleral depression, pushing it from behind, some more comes, some more comes. You don't have to get 100%, but you think you got 100%. You probably leave it behind a little bit. Impossible to totally 100% take it out, but close to. Then I sutured those posterior sclerotomies as well. And then the rest of it is retinal detachment repair. You may see that there was a hole actually in the inferior 6 o'clock in this case, that which later necessitated some more laser. And to be sure, I extended the peripheral barrier laser a little more posteriorly in this case. And the rest is just a regular PVR repair or recurrent retinal detachment repair rather. Air fluid exchange, I do always air fluid exchange before injecting oil, and perfluorine is removed that way. And I use a separate syringe and cannula and inject it so that I'm sure I'm watching the tip of the cannula always as I'm injecting the new oil in this case. And this is the post-op about after oil, the other oil, the one that I put in was removed, and about 2-3 months passed. And this is the picture of the eye where you see retina is totally attached and quite good portion of macula and some midperiphery is preserved. And there is no sign clinically of oil existing in there anymore. And OCT looks pretty good. Patient's vision is about 20/50/60 level due to very mild disturbance of the fovea, perhaps some anterior segment refraction issues, but this is the outcome of the case. So prognosis, like I said, some oil left in the suprachoroidal space is well tolerated, unlike subretinal oil. So if you have subretinal oil, you have to remove that. When you are, when you are doing a repair, retinal detachment, recurrence, etc., for oil from the previous surgery, if subretinal has to be removed. So about in the suprachoroidal space, what I have come across is 2 years cases have been reported with some oil in the suprachoroidal space as well tolerated, asymptomatic. And then after you do all that, sleep well, the eye will do better than you think. Thank you.
Very nice case, Levin. And I think it's something very rare. In my life, I haven't seen any case with the suprachoroidal eye oil. So how many cases you have, Levin?
I got 2 cases. One of my cases, when I was doing the surgery, it got in, and I saw the white reflex, and I stopped and I drained a lot of it. And that patient, as a matter of fact, which I'm not present, I don't have the video. I couldn't find the video of it. It was a 20/20 vision afterwards, where it was nearly full. I mean, it was nearly full. The whole globe was filled up with 4 or 5 cc oil in the suprachoroidal space, and I had to cut down like in 4 quadrants, 8 or so. It wasn't magnificent case, but it did extremely well. It was a truck driver. So that was the 5,000 CS oil, which I found also possible to remove. This was a 1,000. So, I mean, I've seen people talk about it. If you haven't seen, I hope you don't, but one day it may happen.
Yeah. It's very good learning. Yeah. I mean, I've never seen this type of case, and I even didn't know how to remove it, and now I know. So we have Jerry and we have Noor. Jerry, hello. How are you doing there?
Hello, everybody. I'm doing good.
You are a bit late.
Thank you very
so
much. It's 11.
You should be fine.
So I just wanted to comment that this has happened once to me. And this, I think one of the risk factors that need to be mentioned is that patients with pre-existing choroidal detachment. Sometimes patients with rhegmatogenous retinal detachments become hypotonic, then they develop a serious choroidal detachment. And when you get in, you might encounter this, and it has happened to me. And to make matters worse, I was putting in heavy silicone. So, I mean, I don't think, as you said, there's a difference between any type of silicone. And the removal, as you said, is easier actually to remove suprachoroidal oil than it is to remove subretinal oil. I think that's more challenging and more difficult. But I think you handled the case beautifully. Congratulations.
Thank you.
Dr. Noor, any comments, any suggestions?
Thank you, Levent. Very nice case, difficult and a rare one. Myself, I didn't encounter, but I can remember one colleague having it. But as you showed very beautifully, I think with the gravitational force, it just pops out of when you open well enough. And you did very well, I think. And maybe it is best to prevent it. Yes, with always, as you said, mentioned, we should be careful. Maybe sometimes in traumatic eyes, if the choroid is edematous, very thick, or there is a subchoroidal detachment, we should always observe the tip of the silicone oil. I think it is the best, as you mentioned, as a tip.
Yeah, and maybe if you are not able to see it, I think you shouldn't be shy and just make a different, maybe 20 gauge incision. If you're using the Constellation and the BFC pack, it has a 20 gauge silicone infusion or extraction, a cannula that it's longer, and
Yes.
so you might be safer using that if you have any doubts about whether you are or not in the suprachoroidal space.
Exactly, especially in a case like you said, thick choroidal detachments, something like that. If you have that, it's safer to use that.
Yeah, very good, Levent. And yes, obviously, I mean, if you have a choroidal detachment and thick choroid and serous elevation somewhere in choroid, and mostly in pediatric cases and pediatric cases with the giant retinal tear, we usually encounter such hypotony, and in the patients with the long-standing retinal detachment with the PVR, they might have, and sometimes post-traumatic GRT, they present with the choroidal detachment. So in choroidal detachment, there is incidence. I think it's wise, like Jerry said, that we should do the 20 gauge cannula, and moreover, you can identify your injecting line with the endolight, that whether my cannula is in the mid cavity or in the cavity or in the suprachoroidal space. So it depends the situation. So I think we have learned something today from these cases, and it's always better. Thank you, Levent, for your very nice, interesting case. And we have joined the Mario. Hello, Mario. You are still busy. Is it morning or night in Argentina?
No, I'm sorry. I'm my backup, my helper who was taking the surgery in charge so I could be with you. He just faint, 15 minutes before this, so I have to solve some things.
He's
but
okay?
I'm with
He's
you
okay
now. Yes, no, he's okay. I don't care him. I just want to be with you.
Oh, sorry.
His machine is working good, yeah? You don't care about
Yeah,
anything.
the machine is okay. The patient is okay. I don't care about him.
Okay, Mario. So I can introduce the other people. Dr. Mario is from the Argentina, and Dr. Jerry from the Mexico, Dr. Levent from the USA, and Dr. Noor, you all know, from the Turkey. So Dr. Levent has already presented one case, and now we will run a short video about the myome. Abdullah, and then we will do the presentation with Dr. Noor. Okay, Dr. Abdullah. Abdullah, can you run the video?
Welcome to a new era, where AI transforms ophthalmology. In Dubai, join elite eye experts. Discover breakthroughs. Shape the future. Don't miss it. Be part of the revolution. See you at the 6th meeting.
So now, Dr. Noor, will you please share your case?
Okay. Mm,
Yes, it's okay. You can enlarge it.
yeah, I'm just trying to do it.
Yes,
like
it's
this.
okay. You come to the slideshow.
Okay, nice.
Oh.
Now,
No, you come to the slideshow. Go to the right bottom and slideshow. Slideshow is
Yes.
here. Yeah, that's perfect. Click it. Yes, good. Yes.
Okay,
Noor.
thank you. So I picked the case with a diabetic traction retinal detachment. Actually, she is a female type 1 diabetic eye, referred from abroad, 32 years old, but with a bad, poor diabetes control. She lost the other eye doing a surgery in some other country, but she lost the vision, the light perception. So that was the only seeing eye with 20/200, and she had slight cataract, posterior subcapsular cataract with a diabetic traction detachment and vitreous hemorrhage. And she has done no laser treatment before. So I prefer to do an injection, anti-VEGF injection only 2 days before. And then this is just to show the vitrectomy. I just want to say this is, sorry. So I did first the cataract surgery, put the IOL, and then because of we need the hooks. I just want to show this a 23 gauge video. I feel comfortable so the macula was, luckily, after cleaning the vitreous hemorrhage, we can see that the retina was very fragile. And there are lots of tractions, focal tractions, and without any laser in a poorly diabetic control who is prone to bleed during the surgery. I start with, of course, to delaminate the posterior hyaloid, but as you can see, it's very attached in the optic nerve, optic disc, and so I try to peel wherever I can from the macular area, but whenever I touch, she's still bleeding. Sorry, pardon. Okay. So, sorry, what's gone? So as you can see, she's prone to bleed. So that is what I do. We always try to, with the Okitone, can delaminate and dissect and delaminate. But this is something that I feel myself safe in these situations, for example, because I can see the macula is really nice with a very nice prognosis of vision. I try sometimes. It's a good way to dye the membranes with a dual blue or a triple blue, and you can see the membranes much better. And this is the endodiathermy with a very thin, like 23 gauge or 25 gauge, you can prefer, just to lift the membranes. So I feel myself actually very safe as I have my endodiathermy with me. We can do visco dissection or with the probes, with the new kinds of new design probes, which are suited the retinal surface better. But as you can see, this needed a kind of bimanual surgery because the vitreous there are many layers, vitreous crisis. It's very attached and very prone to tear because the retina is really fragile without any laser. So with the bimanual technique and also with very light endodiathermy, again, to the membranes or a bit vitreous maybe, just to lift with the heat energy the vitreous, and then you can use the probe as well as with the scissors. And this is the scissors that I like with a blunt tip, which I like, because with the sharp tip, you can just prone to bleed the retina, or the vessels. But with this blunt tip, actually, it is really nice and safer, or causing less bleeding. And I proceed very gently, because as you can see, there are some focal tractions in the mid periphery, also until the periphery, and which goes, if we aspirate all together, it can easily cause a tear. So I'd like to show this, that using this gentle and safe technique. And about the bleeding, of course, we have to be quick, not to let it coagulate, because it becomes like membrane. It's not easy to peel sometimes, because these patients are prone to also coagulation. Their blood chemistry is also not normal. And as long as we clean the hemorrhage, putting some heavy liquid to prevent bleeding from those vessels, and endo laser treatment, because she had no endo laser. And so that is what I did, especially starting from the periphery with indentation bimanual. I do all the laser. I think it is the only way we can do during the surgery. After the surgery, in a pseudophakic eye, or she may bleed, we cannot complete this endo laser. So this is the end of the surgery. I ended up with silicone oil, because I don't know what is happening, but there's some mixing. So silicone oil removal was available at the 4th month, with additional some laser sessions, and the visual acuity increased to 200. Sorry, there should be OCT images, but with a very nice macular layer, with no edema recurred during the follow-up, and the vision was 220/220. So I just like to emphasize this case, which ended up with a very nice outcome. Thank you for your kind attention. I don't know.
Thank you, Noor, for a very interesting case. Yeah, a diabetic TRD is always changing. It depends on what day you are having, a good or bad. So, any comments from the panelists, from Jerry, Levent? How you people proceed with the TRD like it? Do you inject anti-VEGF before this vitrectomy?
Yes, I try to inject all of the patients, and try to do that just maybe 3 days before the surgery. That way you get a very nice, like drying effect, without risking the crunch, like the secondary TRD thing, which is quite rare. I mean, I think that we kind of overestimate the risk of it happening, but when it does, it actually is pretty bad. So 3 days, I think it's quite safe.
Okay, Levent, how many days before vitrectomy you inject the anti-VEGF?
Yes, I was going to just comment on that too, that I was going to ask Noor if you injected prior to surgery in this case.
Yeah, I injected.
Did you inject in that case, Noor?
How many days before? 2 days before.
She was from abroad. She didn't have much time. That was the reason, actually. 3 days, I think it's better. 3 to 5.
What does everyone, I don't know what what does everyone think about it, but depends on the case, of course. If you have a very, very thin atrophic retina and very strong membranes and juicy vessels that you inject, and traction can cause tear. However, it's, I think, over exaggerated, rather not so active. There are a lot of patients with some neovascularization and some traction. Not everyone gets tear. It's tear, I think, is less than what we think they get. I have lots of patients who can't go surgeon's plan, can't go under surgery. They keep getting injections. They do pretty well with the just injection. I'm prepared to do their surgery emergently if they do. I observe them and keep them, warn them. But I'm less concerned that there's strict certain this many days until you do the surgery. It's like you got to do the surgery in a week or two. That was in the beginning 10, 15 years ago. I was more meticulous on that timing. but I'm just in rather not so active, very juicy retina with very thin atrophic retina patients.
So
Well,
Mario, what are your
yes,
comments?
I think Levin is good the name because I was a co-author of that paper that prevent about the risk of fractional retinal detachment after Avastin before surgery. And I agree, if you see that paper and if you see the pictures in that picture, in that paper, it's exactly what Levin is just said. It's a very juicy. It was my patient, and it was a very juicy retina and membranes, and of course you have this kind of crunch, but because it was very neovascularized, but not all the patients. I think that we overreact to that patients. Everybody's talking about if you put an Avastin just more than 4 days or a week before surgery, you're gonna die. It's not like that. You can use it as you want, and just in very special and very neovascularized patients, you really have a risk. So I think that that is a good point. And I wonder, Noor, after that perfect and amazing surgery, what do you use? Of course, I guess, I don't want to say of course, but I guess you left oil after that.
Yes.
What kind of tamponade did you left?
In this case, because she was the only seeing eye, she would fly back to her country in 3-5 days, let's say, not some more time to stay in Istanbul also. And I did laser, a lot of laser actually, but she was prone to bleeding. So I preferred oil. And I removed it maybe when she came back, like 3-4 months only. I could prefer to remove it earlier, like 2 months, but I could not because she wasn't able to come. If nowadays, for example, I see this lady and she can be staying in Istanbul and I can see her frequently, for example, and I did a lot of laser, all the laser, maybe 2,000 shoots, I don't know. And I will inject anti-VEGF at the end of the surgery, maybe half dose, and put gas because I did the cataract also, and do the more follow-up, frequent follow-up, for example. So it depends on patients, I don't know, what would you prefer?
No, I think that it's a good thing to remark, because when we go to the American meetings, for instance, they tell you no. If you have a patient that has any risk of bleeding, you don't have to use. It's banned to use oil. And I think that this is because they don't have the patients we have in our countries, because it's impossible to leave a patient like this just with air or gas, because they're going to react in the following 1 month and 2 months. So I don't want to take more, but this is just
but it's a good point.
that oil is not forbidden for this patient. Absolutely not.
I
Yeah,
agree.
Mario.
We have done a lot of experience with the really bad cases with oils, and you can manage them, after. So I'm not afraid of oil, by the way. I'm with you.
Okay.
So thank you, Noor and Mario. I have one comment regarding this anti-VEGF. I don't have a regime like I will inject it 3 days or 5 days. It depends on my patient. Maybe you agree to this point. So if the patient has a more vascular component and less fibrous component, you understand, there are more vessels and less fibrous, then I will inject the anti-VEGF at least 5 days before. So I need less bleeding, less vascular component, and more fibrous component. Okay. The other patient has a more fibrous component but less vascular component. Here, I will inject only 3 days before, because there should be some logic of injecting the anti-VEGF. It's not like this, like as we talk in the meetings. I always heard, I inject 5 days before, I inject 3 days before, I inject 2 days before. It's not a rule. The injecting time of anti-VEGF, it depends on the vascularity and fibrous component of that eye. It's not a fixed day. You can inject it even 2 days before when you don't have a minimum vessels. Then you can inject just 2 days before. If you have a more vascular component, then you have to inject it at least 5 days so you can regress the vascular component. Otherwise, it will bleed like a hell and it will complicate your surgery, prolong your surgery, and when your surgery is prolonged, your inflammation is prolonged. When inflammation is prolonged, there is a more transudation and exudation. When transudation and exudation in a fragile retina, like a tractional retinal detachment, it is a horrible vision at the end. So my logic is about this, that when I inject, I don't follow this rule of 2 days, 3 days, or 5 days. It depends on every patient, how his retina looks like. And second thing is regarding the injecting the oil, I agree with the Mario that when you go to the US, everybody's no oil, no oil. Levin, sorry for this. No oil in any eye, oil will kill the eye. Believe me, the TRDs that I am getting, if you will put gas or air in those eyes, after 2 weeks, they will have a choroidal detachment and cavities full of hemorrhage and retinal detachment. One thing. And second thing, I at least in a week operate 5 to 6 TRDs. Believe me, in 5 to 6 TRDs, every week there are half of the TRDs where I have to inject the silicone oil. I inject 1000 silicone oil and I remove it exactly after 2 months. I don't keep it more than 2 months. And my eyes have a never ever complication from the silicone oil, and the retina is healthy. It's far better healthy than the air and the gas, and they get to the VN69612. So it's talking about that oil is killing the eyes. It's only in the US.
I use oil a lot. Okay. Yeah, I'm totally you know in that group, at least I can tell you that. But if there is, I think the one in like Noor's case, for example, the one you just presented, yeah, if there was no hole or there was no suspicion of a hole, and I peeled all the membranes from that, that I don't think there's gonna be any tear from existing or heme blood there forming membrane and immediate tear in a very thin area, I will not be putting oil. But that case you just presented, Noor, was exceptional because one eye. So a little bit of bleeding would take away all the vision in that patient. You want a little bit extra safety that you're putting it just in case some more traction happens following surgery. Otherwise, if there's no traction, you don't have to put a tamponade, oil or gas or anything. So, but in this exceptional case, yes. Plus, even if it bleeds, it's not going to be within the oil. It will be just dragging down out of the visual angle axis that patient will continue to see through the oil, at least some. So I can see the place of the oil in that, but otherwise, if there was no traction, I would not inject necessarily a tamponade.
No,
Okay, I agree. Yeah.
And also, I think if we peel all the hyaloid, all the vitreous cases, everything, even the eye can bleed in a silicone oil filled eye, this hemorrhage also will go away. I mean, I don't see much membrane happening because of the hemorrhage in a silicone oil eye if properly vitrectomized. Do you agree with me? Do you agree with me?
I agree. Agree. That's very serious point. The case that Noor has presented, the only eye, and even if I don't get any break during surgery, but I never know that I may have some micro break that is not visible during the surgery, and it's not popping up during the surgery. And if I leave the eye with the BSS, and next day or after 3 days I get a retinal detachment rhegmatogenous in those cases, so I would rather prefer to inject the silicone oil rather than taking the risk. One. Second, the patient is only eye. So this is the second reason, I think, in the Noor case. And third is that she is traveling. So I think she had a justified decision for this case. Our decision should be according to the case. There are no rules in the science. We should, rules are made only in the books. not on the patients. So for the every patient, we should have decide something from those rules. If we will blindly follow these trials, these rules, then it will be like a guinea pig surgery, like we did in 10th class in laboratories. Every time our frog died.
Yeah. Thank you.
Yeah, now if we have any comments, so I will move forward to the Abdullah and he will run a short video. Any comments from the panelist? Noor, thank you for great surgery
Thank you. Thank you.
and looking great today. So that's we have a video from the myome. Yes, Abdullah.
In every glance, there's a world of beauty, connection, and opportunity. But sometimes, an unexpected injury can turn that world upside down. In a city where innovation meets compassion, experts are coming together to make a difference. Welcome to the 6th MIOM in Dubai, one of the Middle East's largest gatherings of ophthalmology professionals. Together, we can bring back the smiles, the joy, and the wonder in everyone's eyes.
Okay, thank you, Abdullah. So now I will request Jerry to present his case. Jerry is from Mexico and he will introduce himself about his workplace and the weather in Mexico nowadays.
Thank you, Hussein. Thank you very much for the invitation. Also to Dr. Alhambri, and it is great to see you and say hi to you from Mexico City. Let me share my screen. There you go. And just let me know if you see my presentation. I think you do.
Yes, epiretinal membrane, it's clear, yes.
Okay, good. So these are two cases of epiretinal membranes. And you know, most times epiretinal membranes are easy. And we all wish it would be like this, you know, like just one pinch and pull, and it all comes out in a single movement. There you go. Maybe a little blink there, but nothing extra. And then, you know, within 5 to 10 minutes, you are ready to move on to the next case and take your money home. But sometimes they are not so easy. So this is a case that was operated at my hospital, not by me, who had a rheumatogenic retinal detachment with PVR, and he had a scleral buckle, vitrectomy, silicone oil, and an inferior retinectomy, and then he was lost to follow-up for several years. And then he came back with the cataract that you can see here, and the plan was to remove the cataract. The retina was attached by ultrasound, so the plan was to remove the cataract, remove the silicone oil, and then see what was happening inside the eye. So here you can see it was a mature cataract. It was actually a little bit hard, but it came out without a problem. Now, according to the chart, the patient had a regular silicone, but as you can see here, it actually was heavy silicone. And this phenomenon happens sometimes when perfluorocarbon liquids, when PFO, where heavy liquids are left within the vitreous cavity with regular silicone. Eventually they will mix and they will form this kind of heavy silicone that is also called sticky silicone. You can see here the optic nerve is over here, and you can see the border of the inferior retinectomy, and there is, as you will see here, there is a lot of fibrosis, and maybe you can call this perisilicone proliferation or something like that. Now, what I used to, as you could see here, what I used to remove heavy silicone is a venipuncture catheter, 20 gauge, that I cut to make this bevel and insert it through a 20 gauge incision. And whenever the silicone oil is removed, then I will close the incision with 7/0 Vicryl, and I will continue the surgery through the trocars. Now, when I remove the silicone, as you can see, there is a very thick fibrosis covering the macula. And the thing is, sometimes, as you can see here, I'm approaching the membrane with ILM forceps, but sometimes these membranes are so thick and so taut, so rigid, that there is no way that they can deform in order to get into your forceps. So what I'm doing here is a 27 gauge long needle, and it's curved at the point, at the tip. So this is a handmade pick that I do for these cases. And the goal here is not to remove the membrane with the pick, but just to create a little tear in order for the forceps to get into that very tight spot. So as you see here, I am ripping a little bit the membrane. I still haven't gotten through, and there you can see that there is a rip in the membrane, and I can start, pulling it to separate it from the retina. Now you can see here that the border of the inferior retinectomy is very close to the inferior temporal arcade.
Gary,
And
only a
yes.
Mexican macho would start over the phobia.
That's how we roll in Mexico, my
Yes,
friend.
I know you. I know you.
Then I am trying to separate, to tear the membrane, trying to approach this part here inferiorly, but you see that it is pretty adhered, and I don't want to pull too strongly over there. So I decide to run to the other side, over to the optic nerve. The membrane, as you can see, is really thick, is really adhered. There is some hemorrhage resulting of the traction, that the membrane is really close to the vessels. Now I want you to pay a very close attention here, because in this movement you can see that with the membrane, I am taking the superotemporal arcade over here. So as you can see, the vessel was attached was more attached to the membrane than to the retina itself. So here we have some iatrogenic damage to the superotemporal arcade. It looks like a vein because the flow was from backwards and wasn't very high pressure, but still, this is something that you don't want to happen. And the thing is here, in the macula is almost clear, but you have on the inferior part, the membrane is pretty adhered there. And in the superior part, it is adhered to the vessel. So the only remaining thing to do is to try to clear the membrane in between these 2 points of very strong adhesion. And that is well, I'm trying to recover from the shock, just tearing one of the major retinal vessels. I asked for a change of pants, and then I continue my surgery. Here I just detach the part that was adhered to the fovea. I see that I cannot pull anymore, and so I handle the membrane doing this kind of a retro shave maneuver with the vitrectomy probe. The fovea is clear. Still, I try to changing the instrument to the other hand. I try to get as much of this membrane as possible, knowing that the fovea is clear. And regarding the vessel, there is actually nothing that can be done. It's already broken, and you cannot attach it. But I just left it there, trying to separate this bridge that you can see here, so the vessel is free. There it is, and the patient was left under air, no redetachment, and fortunately, no major vascular complications from this. So I would like to know your opinion, and what would have you done differently, if anything?
Jerry, very nice case. Yeah, sometimes it's very easy, and sometimes it's very difficult. Recently, I have a similar case, but he didn't have a retinal detachment surgery. He went for a vitrectomy for vitreous hemorrhage. Okay, And after 1 year, he presented with the epiretinal membrane, and it was very easy overlying the membrane. I thought I will do the ERM membrane peel, and then I will do the ILM peel, and everything will be fine. When I started with the plucking of this membrane was very easy at the temporal side of the macula along the superior and inferior arcade, but it was stuck on the temporal margin of the optic disc. And I mean, it half disc away from the temporal margin, not on the disc, it from away. So I tried to little bit pull it, and you did a wise decision. I tried to pull it, and I saw the retinal detachment underneath this membrane. So then I stopped and just I trimmed it 360 degree and left it there, and I left the patient. I didn't proceed for the ILM peel. I left the patient with the SF6 gas, and luckily he is fine after 5-6 weeks. So that's just the point as you did. If you had pulled this membrane along the inferior arcade, you could have seen the same thing, maybe a tear over there. So not every epiretinal membrane is sticky like a mayonnaise. It may be sticky like a glue.
Of course.
So Levent, yes, Noor, yes, please.
Me? Okay, thank
Yes.
you. So you are very nice. It's a very interesting case because this is a different membrane. This is with the related to the PVR
The
membrane.
PVR, of course,
Very
yes.
inflammatory, and then and very especially it is very attached to the vascular arcades. We know that. I mean, pathological adherence. So I would start with you like through the fovea, because we can see that is elevated there. Maybe OCT can be very nice, Gerard, before the we can plan your surgery, and then after you open very nicely in the middle, and I would do with the cutter, and from inside to outside from the vascular arcades, I wouldn't pull with a forceps, rather I would cut and delaminate the central and then leave it like that, because there's no detachment, as I can say, only the epiretinal membrane in the macula. But you did very beautifully and very interesting case with the
yes, thank you, Nora. And this, of course, these membranes are more related to PVR. And actually, we call, instead of calling this macular puckers, we call this, I'm sorry for what I'm about to say, but we call these mother puckers.
Retrospectively, it's easy to talk retrospectively. If you just left the macula cleaned up, that wouldn't have happened, but that's retrospective. So do you plan to do something differently in the next case? This is like 1 in a million. Like, you're not going to have this easily again.
Yeah, I think it's hard to face cases like this. But for example, after creating this first, dissection plane, maybe the best idea would be to just go straight with the cutter towards the temporal side in order to split, the inferior and the superior membranes, much like we would do in a diabetic TRD. It is wise to separate the inferior membranes from the superior one so you can pull more comfortably.
Cases like that, is it fair to say that this case has been for years and long? So it's not the immediate risk of any risk of retinal detachment at that point. Just, we should perhaps be just so conservative, clean up the macula and don't touch anywhere else, because this is the vessel this time, but other time you may pull off the edge of the retinectomy. So it's just best to just clean the macula as little, optimally, fairly, but then leave the rest of the membranes, because that's the macula at the end that you want it to stay.
Yeah, thank you.
Yeah, yes, the worst thing we can do is to go with all these membranes that overgrow from the retinectomy area, are very, are very tense and tight, and every time you feel like tempted to, well, I want to take this one, and you drag a little and you break the retina, and you are all over, that you have to live again, oil, and you start in an eternal loop. So I really agree with Levent. It's the second one. I agree with you. Just do little, just clear the macula, and that's it.
Yes.
When concentrating the macula in a case like that, you don't have an OCT prior to surgery, or intraoperatively you don't have. Oftentimes I end up peeling ILM from the perifoveal area to get the best foveal function. But at that point, you just wanted to leave it and finish it. But
Yes.
might be staining and any ILM left in the macular area might be additional help for that.
Yes, for example, yes, I agree. In cases of recurrent PVR, it is wise to also remove the ILM to remove the scaffold over which these PVR membranes grow.
That's right. That's nice. And now we have our last master from Argentina, Mario. Your turn. He has actually nice OR too. You are in OR or in recovery room with your friend?
Estás silenciado, Mario.
Mario, no sound.
Okay. Do you hear now me?
Yes, it's
Yeah.
okay. Yes.
Okay. No, it's my OR. Yes, I'm very, very proud of it. Yeah. Beautiful. 3 ORs. Beautiful. And they work a lot. Well, I'm here. Do you see the right
Yes.
way? I mean, are you
No,
okay?
you need to activate the slide show. Yeah.
The slide mode like this?
There you go.
Yes.
Okay. So, well, I'm just trying to, here in Argentina, I made the only 4 cases of liver atrophy that were treated in my country. And I'm starting, I know that, I remember when I went to Dubai that somebody had like 14 cases or something like this. So this is not for him, but for the rest of you, probably at some point, we are going to do this. We are going to treat these patients, and I think that maybe I can let you know some tips that I'm learning. Let me. I'm trying to move the.
Yeah. It's okay. Next.
It's okay. Is it white or what?
Yes.
Okay. Well, this is a 16 years old patient with liver congenital amaurosis, and his visual acuity was hand motion. Actually, he needed help to get through the door to come to my office. So he was almost blind. In the first case, in the first eye, was the right eye. Sorry, I'm a little, okay. I'm not sure if, okay, this is it. Just.
No se ve video, Mario.
¿No se ve el video?
No, se ve oscuro completamente.
Tap it. Next slide.
¿Ahora? ¿No?
No. ¿Tú sí lo ves?
¿No? Sí, lo veo perfecto. Oh, bueno, qué problema. Bueno.
A ver, si quieres, salte. I'm sorry, I'm going to talk in Spanish. Salte de la presentación y reprodúcelo dentro de la diapositiva. O sea, dale escape.
A ver.
Okay,
vamos a ver. ¿Ahora qué hago? Espérame un poco. Vos decís algo como esto.
Sí, que le piques ahí una vez.
Ahí?
Sí, pero no veo video, no se ve video. O sea, debería aparecer el control.
Yo tampoco. Ok.
Double click over it. Double click it.
Double click en esta.
Yeah. No, there's nothing.
That's what I'm doing.
There is nothing wrong.
Okay.
But this is a very good demonstration of how the patient was seen.
Yes.
Yes,
Blank.
no, I'm trying to, yes.
Mario, you
I'm
can
trying to
open
put
your
your
video file instead of close this sharing and open if you have separate video
You
file.
have a video on the desktop,
Uh-huh.
on the laptop.
let me check
But
again
take your time.
if I can.
Take your time. No rush. Meanwhile, we are learning the Spanish. Good and bad.
Yes, probably.
Yeah.
¿Me ayudas? A ver
I'm
si
writing
puedo.
the Spanish in the chat box.
No, so sorry. No, I'm trying hard to fix it.
No, it's okay.
A ver si me...
Don't worry, Mario. This will be immortalized in YouTube forever. No worries.
You know, I know I have helpers and they know, they are, you know, okay, put it like that. Lo que quiero es que corra, sí, pero que corra el video. Esto sí. Bueno,
Play it.
I saw it running. See, are you seeing it? No.
No, it's a blank slide.
Wow.
Maybe
¿Cuál
it's
otra? A ver.
embedded in the
You get it from your
Otra.
system.
¿Esta? ¿Compartir? No, cualquiera. Salgo acá. No. Para. Escape. Well, just give me a minute. I have a couple of brains working here. This is
Okay, you carry on. So,
no.
guys,
What I was trying
yeah.
actually.
Yes.
Ahí? Are you seeing it?
Yes.
Yes.
Okay.
Sí, perfecto.
Okay. Well, this is this was the right eye. I start my first bubble very gently, but I had to press a lot. And at some point, I have an unwanted, air bubble there. And I said, well, okay, so now the drug is over the fovea, so it's going to, that's okay. That's nothing to care about. But I will tell you later what was the problem. In the second one, and we had problems. So in the second one, I choose a different technique. First, to really to clearly detach the hyaloid, and then I used dye, blue brilliant, and I didn't take the ILM, but just make a very little like this, very little ILM holes. And when you do that, doing the bubble, it's very gentle, so you can really control how much drug are you injecting, the size of the bubble and whatever. But like that. But you see that I spare the fovea. So now to show you what is the difference using these different techniques, what the results are. A ver, mostrarme esta que sigue acá. ¿Está bien? Share a esa.
While the slide shows,
Vamos.
Mario, when you're doing a TPA injection, you also do this ILM peeling?
No, but doing, because I had this problem with this patient, I start to think about, yes, okay, why not? So if you try, you all do bubbles with this, with the 33 or 41 cannula, and you know that you have to press a lot before to break the resistance of the retina. So when you start with bubble, then it's like it's an easygoing flux. But first you have to press a lot. If you take the ILM out and the hyaloid out, that is more gently, So I don't know. It's my experience. Just try to do that. But the other thing that is interesting is that when you see in this peak how the size and the size of the atrophy that you have in the right eye, it was, it really scared me. But there were another difference. In the right eye, I also had some, after the surgery, I had haze, and so some inflammation. And in the second one, I took care to inject triamcinolone, and I don't know if this could be a difference, but now I put triamcinolone in all of them. But I just wanted to show you the difference in between the atrophy. Now, in the color pictures, the atrophy looks like the same, but it's not. In the left eye, the pigment epithelium atrophy are very slight, and in the right eye, it's very, very strong. I don't know why. What is it's supposed to be lutein or something that really protects the fovea, because the atrophy spared the fovea, but the functionality was not good enough in the right eye. And in the left one, it was amazing. The results were, let me just to point you what were the difference: a big central bubble and small peripheric multiple in the left eye, to take out the hyaloid and the ILM, and the anti-inflammatory add of triamcinolone, because the laboratory, they recommend you just to use intravenous Solumedrol, and that's it, and it's not enough. So just take that in. Have the and okay, and about visual acuity in the right eye. No, the vision wasn't counting fingers, but 2800 or 2400. And in the left eye, it was amazing. This guy really,
Wow.
really improved a lot, and we are really making a difference in his quality of life. I want to show you just now a few images about what is he doing in the school, and this excellent. Show me that video. This is Benjamin, just few months after the surgery, and he was absolutely blind. And this is a message from the mother, showing me the draws and the carpentry handcraft he's doing in the school with. So it is really something that makes a difference. It's really expensive. It's it's very hard to get this patient treated, at least in my country, because the drug is about hundreds of thousands. But I really wanted to share with you this little experience, because one day all of us are going to be treating these liver patients.
Okay, thank you, Mario. Do you have any comments or suggestions? Noor, Jerry, very nice surgery, and I'm really amazed by the Luxturna outcomes. I thought Luxturna is just for money, but from these outcomes, I think it's a very good outcomes. 2040 is excellent vision in young boy. It's amazing. So yes, Jerry, Noor, anything to add?
Just the thing that I commented earlier, I mean, I was amazed how different was the injection, the ease with of the injection between peeling and not peeling the ILM. And I know we will. I haven't done any Luxturna, patients yet, but I have done subretinal TPA for some macular hemorrhage, and I agree with you. I mean, even if you cut the 41 gauge needle and bevel it in order to have a like a tip to slide easier into the retina, it's actually pretty hard. And what I'm thinking now is that I will try to peel the ILM and the next patient that I have to see the difference, because it looked like it made all the difference, and it makes sense because the ILM is one of the not thickest but like toughest parts of the retina, so it makes sense to take it out.
Yeah, ILM is a
No,
stiff
well,
membrane. It doesn't have elasticity. That's wise decision, I think, Mario.
No. I'm just trying to say that when you have a staff of $500,000 in your hand, and if you fail, and you have like 14 people in your back, watching, you start to be, you become like more creative, and you try to reduce the margin of errors or whatever. So I was really scared the first time, because like you all, we did these bubbles, injecting whatever, or sometimes just to detach the retina, or injecting TPA, but you don't care. Actually, I didn't remember if I had some troubles or if it was hard. But when you're pressing like this and you say, oh my God, if I fail, oh my God, if I fail, well, you say, okay, let's try to do it. Let's try to make this easier. And actually it works. It works. It is really easier or you have to push less. That's it.
I agree also, Mark. It's a very nice that you peel the ILM, although it is not easy in these little kids. But whenever I inject something under the retina, I always like with a small peeling at that area, because I know the feeling that it's elastic. It's like a barrier, the ILM, especially in the young patient, I think. And but the result is amazing. Already 16 years old, the vision is very low, but 20/40 is really amazing. And for the right eye, did you remove the hyaloid before or no? And directly, it wasn't clear, because in your table you wrote that in the first eye, right eye, no PVD, no ILM peeling. Is it so? Directly, I mean, injection.
What do you mean directly? If I inject
without PVD, I think you did the PVD, posterior.
Yes, at the beginning I didn't do, because I was asking, because before they give you this drug, you have to go through a lot of courses and recommendations and whatever, and so they asked me to be minimalist. So just do a core vitrectomy and then inject. So okay, because in my mind, if they didn't do anything, I would peel the eyelid. But they told me, no, just don't touch, because it's a risk if you do something, or if you, I don't know, if you hurt the macula. This is a different thing, because it's such an important or iconic treatment that you have so many people calling you. But I guess that when they brought the drug, they brought with a custody, with two cars. So it's funny. But in the first side, so I didn't peel the hyaloid, and in the second one, I thought, okay, I'm going to do it my way, and this is what I show you. The difference are quite
very
evident.
dramatic. Yes. Thank you. Very nice. Yes, we haven't done any Luxturna in Turkey yet, by the way. Too expensive.
Sooner or
And-
later, all of us will have that.
Yes, I agree.
Abdullah, can we run the video? Abdullah.
I'm Dr. Heba Mutwalli from Egypt. Join us in the 6th MIOM conference. Let's meet there for a remarkable journey in ophthalmology in the glorious Dubai city.
Hi, I'm Susan Jacob from India. Join us at the 6th MIOM conference. Let us meet there for a remarkable journey in ophthalmology in the glorious city of Dubai.
I am Dr. Züleyha Yalnız Akkaya from Turkey. Join us at the 6th Middle East Ophthalmology Meeting Conference. Let's meet there for a remarkable journey in ophthalmology in the glorious Dubai.
I'm Dr. Matteo Forlini from Italy. Join us at the 6th edition of NEOM Conference. Let's meet there for a remarkable journey in ophthalmology in the glorious Dubai city.
So, Noor, thank you, Mario and Levent and Jerry, all of you for joining us, and hope you people are busy. Now, I mean, it's midnight in Lahore. I think it's late in Istanbul, but it's afternoon or noon in Mexico. So, Jerry, enjoy your clinic, and Noor, have a good night, and Mario, enjoy your OR, and Levent, he is also enjoying his hospital. So, take care. Hope to see you soon in somewhere, maybe in Mexico in October. So take care and have a nice day. And thank you so much for your presence.
Thank you so much.
Take
Thank you.
care. Bye-bye.
Bye.
Thank you, Hussein.
Thank you.
I hope one day I can have you here.
Sure. I will be glad. So thank you. ¿Cómo estés?
Bien, amigo. Muchas gracias.
Oh, no, not such long reply. You get ask the beyond like this. Okay. Have a nice day. Thank you. Take care. Bye-bye.
Bye.